All right, so our finalists, as a reminder, they won $500 each yesterday, and the winner of today's runoff will win an additional $500. Each finalist will have 4 minutes to present, followed by 3 minutes for discussion, and we will be very strict with the timing in classic Karmody fashion, and our first finalist is going to be Dr. Priya Patel, Life-Altering Events Following Endovascular Aortic Repair in the Vascular Quality Initiative. Dr. Patel.
Thank you for the opportunity to present. I have no disclosures. Endovascular aortic aneurysm repair is associated with improved perioperative outcomes when compared with open repair. However, the postoperative mortality and morbidity risk after endovascular repair cannot be ignored, especially as advances in technology allow for repair of more complex aortic aneurysms. Roche et al. Previously described TAIL as a composite outcome of adverse, life-altering events that occur after thoraco-abdominal aortic aneurysms repair. TAIL is a composite outcome of postoperative mortality, dialysis, paralysis, and stroke. The objective of our study was to determine if TAIL can be used as an outcome measure after all forms of endovascular aortic aneurysm repair. We used, our second aim was to identify patient level as well as anatomic and procedural level variables associated with TAIL. We conducted a retrospective cohort study using the VQI registry from 2011 to 2021 to identify all patients who underwent endovascular aortic aneurysm repair. Patients were stratified by repair type. The different repair types were defined by their proximal and distal aortic landing zones. Repair types included infrarenal EVAR, complex EVAR, TVAR, extent 1 to 3 thoracoabdominal aneurysm repairs, and aortic arch repairs. Our outcomes of interest were postoperative TAIL, as well as factors associated with TAIL. Once again, TAIL was defined as a composite outcome of postoperative mortality, dialysis, paralysis, or stroke. We used univariate variables to compare postoperative outcomes and mixed effect regression modeling with clustering at the center and physician level to identify factors associated with TAIL. TAIL occurred in 1.2% of EVARs, 4.8% of complex EVARs, 6% of TVARs, 10% of thoracoabdominal repairs, and 14% of aortic arch repairs. Similar trends were observed when we compared postoperative mortality and stroke rates. Postoperative dialysis occurred more frequently after complex EVAR and thoracoabdominal repairs, while postoperative paralysis occurred most frequently after thoracoabdominal repairs. While discharge to skilled nursing facility was not included in the original definition of TAIL, these rates are presented here with the highest rates observed after thoracoabdominal and aortic arch repairs. The results of our mixed effect regression analysis are presented here. We found history of coronary artery disease as well as chronic kidney disease was associated with higher odds of TAIL after most repairs. Larger aortic diameter at the time of repair was associated with higher odds of TAIL after infrarenal EVAR, complex EVAR, and TVAR, as well as aortic arch repairs. More proximal landing zone was also associated with higher odds of TAIL after complex EVAR, TVAR, and thoracoabdominal repairs. So in conclusion, TAIL occurred more frequently after thoracoabdominal and aortic arch repairs. Chronic kidney disease, as well as coronary artery disease, in conjunction with larger aortic diameter and more proximal landing zone, were associated with higher odds of TAIL. Aortic anatomy and operative steps should be factored into preoperative clinical decision-making. Lastly, the postoperative risk of TAIL should be incorporated into the preoperative counseling discussion for all patients. Thank you, and at this time, I'd be happy to take any questions.
All right, we'll start with questions from our judges. Judges?
Nicely done. The other factors, for instance, shaggy aorta, and also pelvic circulation in particular, whether that was looked at, presence of patent hypogastric arteries, for instance.
I'm sorry, could you repeat after the shaggy aorta? I couldn't hear what.
And the pelvic circulation, and specifically patency of the internoiliac arteries, and whether that was also looked at.
Gotcha. So we didn't incorporate the patency of the iliacs, but we did account for in certain variables, particularly if there's an infrarenal EVAR, complex EVAR, and thoracoabdominals. We did account for if there was a concomitant iliac aneurysm repair. Here, for the ease of presenting everything in a short time period, I didn't go through the nuances of each regression model, but in those specific models, the complex EVAR patients, if they had a concomitant iliac aneurysm, that was also associated with a higher odds of tail. We did not see that after infravenal or thoraco repairs.
Dr. Timaran.
Just a quick question. It seems you see worse outcomes with arch repair. So I didn't get what arch repair means. I guess you're just looking at endovascular, but when you do arch repair, you're looking also at hybrid repairs? Because I'm telling you, purely endovascular repair, even it's 3 vessels when we do it now with, custom-made devices, appears to be way better tolerated than even, extend 1-3 thoracoabdominals. What arch repair was, how was it defined in the cohort?
Correct. So aortic arch repairs, this was defined as patients that underwent endovascular aortic arch repairs, but we did have some of those patients who had a staged repair. Again, I didn't go through the nuances of each regression model, but in the aortic arch repair, we did account for staged repair. However, staged repair was not associated with tail.
All right. Thank you.
Thank you so much, everybody.
All right, our next finalist is in the aortic abdominal category. Insulin dependence is associated with poor long-term outcomes, but equivalent perioperative outcomes following AAA repair, presented by Dr. Clay Wisk.
Good morning. I'll be presenting a study that we did looking at the long-term impact of diabetes on aneurysm outcomes following repair. No relevant disclosures. So as many people know here, diabetes has been well established to have a protective effect against the growth and development of AAAs. Much less is known about the long-term impact that it has on patients who have repaired AAAs. So our approach to evaluating this question was to look at the VISION database, which is a combination of VQI data with long-term Medicare data. And we, inspired by the orthopedic literature, which actually suggests that insulin dependence is the predominant factor in determining long-term outcomes following surgery, we performed 2 different analyses. The first was to compare all diabetics to non-diabetics, and the second was to compare just insulin-dependent diabetics to everyone else. Our endpoints were perioperative mortality, as well as mortality at 1, 3, and 5 years, and freedom from reintervention. So in terms of baseline characteristics, not surprisingly, people who had diabetes had multiple additional medical comorbidities, including CHF, hypertension, coronary artery disease, all of which we adjusted for in our multivariate analysis. And a similar pattern was observed for insulin-dependent diabetics versus everyone else. Now, looking at our perioperative outcomes, I apologize, there's a lot on here, but the left side is the outcomes of open repair, and the right side are the outcomes of EVAR. The thing to call out here is that in-hospital death is essentially equivalent between these 2 groups, the diabetics in purple and the non-diabetics in gray. There was a slightly higher rate of post-op MI, post-op dialysis, and 30-day readmission among diabetics, depending on whether you're looking at open or endo, but again, mortality was the same. Now looking at the long run, these are our Kaplan-Meier curves comparing diabetics to non-diabetics, and as you can see, there's no statistical difference in long-term survival up to beyond 5 years here. Looking specifically at insulin-dependent diabetics versus everyone else, however, there's a significant and durable and increasing over time rate of increase in mortality for insulin-dependent diabetics versus everyone else. This is true of both the open group and the EVAR group. Putting this in terms of percent mortality, If you look, one of the most notable findings to us was that the one-year mortality for insulin-dependent diabetics was 15% compared to 9% for all others. That's a pretty significant difference, and again, this difference increased over time and was durable, and also persisted in our multivariate analysis, as well as a sub-analysis just looking at elective repairs. So our primary results were, first of all, that perioperative mortality did not depend on diabetes status. However, there was a significantly larger rate of mortality over the long run for insulin-dependent diabetics. And we looked at the rate of rupture. There was no significant difference between those two groups, and so we inferred that this was not aneurysm-related mortality. So overall, our findings raise questions about whether insulin-dependent diabetics should have a higher threshold for elective repair of asymptomatic aneurysms. Thank you.
Very nicely presented. I have a question for you. So insulin dependence is an interesting variable to look at because it could either mean increased severity of disease, or it can mean tighter glucose control over a long period of time, right? So what percentage of patients do you know in the insulin-dependent group were type 1 versus type 2? I would think that type 1 diabetics probably have an increased risk of morbidity and mortality after this type of repair.
Yeah, that's a great question. This is one of the limitations we had. We didn't have access to data on whether or not these were type 1 diabetics or type 2 diabetics, and we didn't have access to A1Cs. So we're trying to go back and link the data in such a way that we can answer that question.
Any other questions from the floor? No? If not, we'll move on to our next presenter. Thank you.
Thanks.
And in the category of cerebrovascular, we have impact of neighborhood social disadvantage on carotid artery disease presentation, management, and discharge outcomes, presented by Dr. Winona Wu.
So recent studies have highlighted that race and socioeconomic status serve as important determinants of disease presentation and outcomes in carotid artery disease. However, these investigations largely focus only on individual factors of disadvantage and fail to account for community factors that may be driving these disparities. Area Deprivation Index is a validated measure of neighborhood adversity that offers a more comprehensive assessment of social disadvantage and community disadvantage. And so we sought to examine the impact that ADI ranking had on carotid artery disease severity, management, and postoperative outcomes. We identified all patients who underwent carotid endarterectomy, transfemoral stenting, and transcarotid artery revascularization in the VQI registry between 2016 to 2020. Patients were assigned ADI scores of 1 to 100 based on their residential zip codes and grouped further into quintiles, with higher ADI quintiles reflecting increasing adversity. Outcomes assessed in terms of primary outcomes included differences in carotid artery disease presentation and differences in intervention type across ADI quintiles. And our secondary endpoints included differences in in-hospital stroke death, MI across ADI quintiles, as well as failure to discharge home and length of stay greater than 2 days. Overall, 91,904 patients undergoing carotid revascularization were included in this study. And with increasing ADI quintiles, patients were overall more likely to be female, younger, sicker with more cardiopulmonary comorbidities, uninsured, and smokers. With increasing ADI quintiles, patients were more likely to be symptomatic, with 52.1% being symptomatic in quintile 5 versus 46.6% in Q1, and present with stroke versus TIA, with 63.1% having stroke in Q5 versus 53.5% in Q1. In adjusted analysis, higher ADI quintiles remained as independent risk factors for presenting with symptomatic disease and stroke. With increasing ADI quintiles, patients were also more likely to undergo carotid artery stenting versus endarterectomy, with 46.4% undergoing stenting in Q5 versus 33.9% in Q1, and specifically transfemoral stenting versus TCAR, with 54.2% undergoing transfemoral stenting in Q5 versus 42.7% in Q1. In adjusted analysis, higher ADI quintiles remained as independent risk factors for undergoing stenting, and specifically transfemoral stenting. Across ADI quintiles, patients were more likely to experience death, stroke death, failure to discharge home, and length of stay greater than 2 days following revascularization. Using sequential logistic regression, we found that increased frequency of symptomatic disease and transfemoral stenting were significant contributors to the higher death and stroke death rates that we found in these patient populations. Conversely, patients with the greatest neighborhood deprivation continue to have higher odds of failed discharge home and prolonged length of stay after adjustment for all these factors. In conclusion, among carotid revascularization patients, those with greater neighborhood social disadvantage had greater disease severity and more frequently underwent transfemoral carotid artery stenting. Higher ADI quintile patients also had higher rates of death and stroke death, were less frequently discharged home, and had prolonged length of stays greater than 2 days. Greater efforts are needed to ensure that patients in higher ADI quintiles undergo better carotid surveillance and are treated appropriately for their carotid artery disease. Thank you.
Thank you. Questions from our judges?
I have a quick question. I have a question regarding the ADI scores. So who specifically calculates these scores, and what specific factors are involved in calculating the scores and classifying them?
Sure, absolutely. So the ADI, the Area Deprivation Index, is created from 17 metrics derived from long-term census data. It is created by the NIH and is made readily available by something called the Neighborhood Atlas, which is available on a website created by the University of Wisconsin. So you can find more details on exactly what the metrics are and how it's calculated, and you can actually readily download that data for the United States for each zip code on the website. The metrics include 17 metrics pertaining to education, employment, poverty level, and income. Is the 4 groups. Yeah, no problem.
Good paper.
Thank
What
you.
possible explanation is for transfemoral stenting and the socially deprived? I couldn't get that. What is the reason? Is it done by non-vascular surgeons, or what is the story?
It's hard to figure that out exactly, and this paper has been published. You can read my discussion, but we sort of postulate a couple of reasons. One, it could absolutely be sort of differences in referral patterns in these regions, whether they're done by vascular surgeons versus interventional radiologists or neuroradiologists. We're not entirely sure, and it's kind of given the limited nature of that data in the VQI, I had tried to do that, but it overall was not that effective. Other things you can see is that, in a lot of places where there's patients encountering a lot of poverty or with a lot of minorities, there's often different cultural perceptions in terms of how maximally or minimally invasive you want to do these interventions, or what personal preferences that patients or those physicians have. But once again, due to limitations of the VQI data, it's hard to parse that data out. Yeah.
All right. Thank you.
Thank you.
And next we have the PAD category, which is postoperative novel oral anticoagulants are associated with improved amputation-free survival in infrageniculate bypasses performed by prosthetic grafts in patients with chronic limb-threatening ischemia, to be presented by Dr. Zorintan.
Good morning. Thank you for the opportunity to present. So, as we know, bypass with autogenous graft is the conduit of choice for infrainguinal bypasses, particularly when the distal target of the bypass is infrageniculate. However, in some patients, autogenous graft is not available, and we're supposed to use prosthetic graft. So different measures have been used to increase the durability of prosthetic grafts in infrageniculate bypasses. In the present study, we aim to investigate the effect of postoperative anticoagulant on outcomes of infrageniculate bypasses performed by PTFE grafts in patients presenting with chronic limb-threatening ischemia. So we used Vascular Quality Initiative Medicare Link database. We used follow-up visits from Medicare database, which are matched to the VQI. And we looked at only infrageniculate bypasses, patients presenting with CLTI between 2014 to 2019. So we end up with 3 cohorts, patients not receiving any anticoagulants, 2/3 of patients, and then patients receiving warfarin, 27%, and patients receiving NOACs, 10%, and NOACs included rivaroxaban and dabigatran. So our outcomes were overall survival, freedom from reintervention, limb salvage, and amputation-free survival, and all the outcomes were evaluated in 3 years. So as we see in our Kaplan-Meier in univariate analysis, NOACs were associated with graded overall survival. However, freedom from reintervention didn't have significant difference among study groups. And for amputation-free survival, again, we see that NOACs had the greatest amputation-free survival. Then we did Cox regression model for the outcomes, and we adjusted for demographics, smoking status, comorbidities, prior procedures, and preoperative medications, and also type of presentation, rest pain versus tissue loss, and anesthesia type, total procedure time, concomitant endarterectomy, use of distal vein patch, and also other postoperative medications, including antiplatelets. So in our Cox regression analysis, we found that both warfarin and NOAC were associated with improved survival compared to not receiving any type of anticoagulation. And NOAC was also associated with improved amputation-free survival compared to not receiving any type of anticoagulation. Then we compared NOACs to warfarin as well, and in this comparison we found that NOACs were associated with improved amputation-free survival compared to warfarin. So this is limited due to the retrospective design, and also we didn't have any data on the duration of anticoagulation use after surgery. And also VQI Medicare Link database didn't capture the different indications for the use of postoperative anticoagulations. So in conclusion, postoperative anticoagulation use is associated with better survival in patients undergoing infrageniculate bypass with PTFE graft for CLTI. And also patients receiving NOACs are associated with greater amputation-free survival. So this study supports the use of anticoagulants, preferably NOACs, to achieve favorable outcomes in infrageniculate bypasses when a prosthetic graft is being used. However, further prospective studies are necessary to confirm our findings. Thank you, and happy to take if any questions.
Judges.
I have a quick question. Why do you think the patients that are on warfarin have a worse mortality when a patient on a NOAC should be anticoagulated and you don't see that mortality difference or that signal? My second question is, do you have information on the indications for Coumadin and NOAC, whether it was just for PAD and PAD dosing, or are they fully anticoagulated for some other reason?
Yeah, thank you. Great questions. For the second question, I would say, unfortunately, we don't have any data in VQI to show the indication why the patients use anticoagulants either before or after surgery. The first question, I didn't understand completely.
In your slides, you have a slightly increased risk of death after multivariate analysis for the patients on warfarin, but not on NOACs.
No, it was reduced death.
Reduced death.
Yes, yes. Because I thought greater overall survival. I'm sorry for the, yeah. So because the table shows the death, and it was improved survival, but increased deaths in both cohorts, in both warfarin and NOAC. Both groups had improved survival and less death.
From the floor.
Hi, Fahad Shuja from Mayo Clinic, Rochester. Thank you once again. One question and one comment. The question is, were you able to distinguish whether the group that received the NOACs, was this the prophylactic dose or the full therapeutic dose? That's the question. And the comment is, I don't think you showed us what is the postoperative risk of putting patients on DOACs and warfarin. So I would just be a little wary of making a suggestion that patients who are having PTFE bypasses for CLTI should just be started on them without knowing what is the risk of significant bleeding complications. Thank you very much for sharing your experience.
Thank you. Yeah, unfortunately, we didn't have any information about the doses of medications, either pre-op or post-op. And thank you for the suggestion.
All right, thank you. And in the dialysis venous visceral renal category, we have comparison of non-autologous hemodialysis grafts, bovine carotid artery versus synthetic, presented by Dr. Richard Mina.
Good morning. Thank you for the opportunity to present our findings on bovine carotid artery versus synthetic dialysis grafts. My name is Anthony Mina. I'm an integrated resident at Emory University. And while vein is the optimal conduit for first-time upper extremity AV access creation, we're all aware that patients oftentimes present with poor caliber veins. So we as surgeons are faced with a difficult decision: which non-autologous conduit should we use? Two of the most common options include synthetic PTFE dialysis grafts, as well as bovine carotid artery grafts. And while they're used relatively frequently in various practices, there's a relative paucity of data comparing the two conduits. One excellent paper was actually published here 7 years ago at SCVS, and it reviewed 134 patients in bovine carotid artery grafts. However, this paper had no comparison cohort. And the only prospective data that we have currently was published in 2011, 12 years ago, and included only 53 total patients, 26 in the bovine carotid cohort and 27 in the synthetic PTFE cohort. Therefore, our objective was to compare outcomes between bovine carotid artery and synthetic PTFE dialysis grafts, specifically for first-time upper extremity AV access creation using a more contemporary and multi-center database. We performed a retrospective review between 2003 and 2022. Our primary outcomes included stenosis and thrombosis rates at 6 and 12 months. And our secondary outcomes included infection rates, mean number of interventions per access, and loss of primary patency, again at 6 and 12 months. We included 295 patients in our analysis. Roughly 3/4 of these patients underwent PTFE grafts. And importantly, within this cohort, roughly 92% had standard grafts, with only 8% having immediate use grafts. There were no statistically significant differences in the baseline demographics or comorbidities between the two cohorts. First, looking at our 6-month data, you can see highlighted in red that patients who underwent synthetic grafts had a higher rate of thrombosis and a higher mean number of interventions per access. And this relationship held true at 12 months, where again, patients who underwent synthetic grafts were thrombosing more frequently and requiring more reinterventions than BCA grafts. There were no statistically significant differences between the stenosis and the infection rates of both groups, and most importantly, there was no difference in primary patency. So in conclusion, at our institution, at 6 and 12 months, we found that bovine carotid artery xenografts had thrombosed less frequently and required fewer reinterventions than those with synthetic grafts, while maintaining a similar primary patency. Moving forward, it would be interesting to see with a larger prospective study to see if bovine carotid artery grafts maintain these advantages over time. And before concluding, I do think it's important to note cost, since cost is undoubtedly important with regard to resource utilization and healthcare spending. And I assumed bovine carotid artery grafts would cost more, which may be a limitation to this study. However, the aforementioned paper published in 2017 and presented here in 2016 showed, in fact, that artegraft conduits cost 36% less than those with PTFE, at least based on manufacturer list price, excluding any possible bundles or hospital discounts. And so, if artegraft costs less up front and requires fewer reinterventions, it really does beg the question that if over time with a prospective study, will BCA grafts still hold advantages? Thank you very much. I'd be happy to answer any questions.
Judges. Questions from our judges?
Great presentation. I have a question for you. How did you determine that the groups weren't different? Did you do a propensity score match? Or did you? And then my second question is how was it chosen which graft at your institution is used? Is there a surgeon preference for the most part, or were there other factors involved?
Yeah, that's an excellent question. For this study, we did not propensity mask. When we do our randomized trial moving forward, we hope to do so. So we just look simply at demographics and proportions of each cohort. With regard to the which choice to use BCA or synthetic grafts, it was very much surgeon preference at the time. We included 4 hospitals within our network, and certain surgeons prefer to use it. It'll be interesting to see if we can create a more standardized protocol within our institution once some more prospective data comes out.
Dr. Hingorani.
I may have missed it in the slides, but were these all forearm grafts, upper arm grafts? Did you look at the constructs? Were they loop grafts? Were they straight grafts? I didn't see that.
Yeah, that's a great question. The vast majority in both cohorts, the PTFE and the BCA, were upper arm, and most were break ax. There were a few loop grafts, but the majority were brachioaxillary grafts.
I have one quick question. You noted in the beginning these were all primary access creations, right? Do you think the outcomes would be different if you were doing redo or after multiple previous failed accesses if you're using these?
Yeah, I think that's an excellent point. I think so. For this study, as a benchmark kind of a jumping study, we wanted to just use first time to avoid any sort of biases with potential redos and central venous occlusion secondary to prior accesses. I think when we do our prospective data, we may be able to simplify in different cohorts based on first time access versus redo access, and that might give us some more clarity too.
Great job. Thank you.
Thank you.
And our final category is Education, Imaging, and Miscellaneous Development and Videographic Evaluation of a Vascular Access Simulation-Based Curriculum for Surgical and Medical Trainees. I do not believe Dr. Pendleton is here, but Dr. Bellomo is going to present.
Hi, thank you for the opportunity to present. I work with Alaska. We worked on this project together at Massachusetts General Hospital, where we're both vascular surgery integrated residents. Here to talk to you about our vascular access simulation-based curriculum. This was funded by the Center of Medical Education at MGH. And arterial line access is the gold standard for accurate real-time hemodynamic monitoring, with over 8 million arterial lines placed in the United States annually. Femoral arterial access is frequently obtained in emergency scenarios or when radial artery access has been exhausted. The failure rate of arterial catheterization is 10%, but actually approaches 50% for patients in shock and emergent situations. And we all know the complications of femoral artery access: groin hematomas, RP hematomas, thrombosis, retained guide wires. And interestingly, there's a paucity of data even teaching students how to use or gain femoral artery access. And so we decided to create a curriculum. Our first aim was to create this curriculum to address the lack of standardized training. Our second was to evaluate the curriculum's impact. And third, to identify the most common errors that trainees face. And so first, for our curriculum development, we enlisted a multidisciplinary collaboration between vascular, interventional cards, general surgery, and emergency medicine, where we created first an in-person simulation training using the Simulab femoral line man that's pictured here. We also created a standardized virtual didactic training that everybody could watch. And all training took place between March and August. So we had 26 participants, 62% were PGY 1 year, and the others were PGY 2. The majority were general surgery residents, 58%. We also had emergency medicine, vascular residents, and radiology residents. And shockingly, 45% of these participants could not even complete the procedure before the curriculum. This was actually reduced to 8% of participants after the curriculum was implemented. To assess the curriculum efficacy further, we actually took videos of these participants before the curriculum, gaining access. We had the curriculum, and then we took videos of them after gaining access. And so these recordings were reviewed and scored by 2 independent blinded investigators. And so here we see the global rating for overall ability to obtain femoral access under ultrasound guidance improved from 0.87 to 2.79. In addition, facility using ultrasound, ability to advance the wire, Seldinger technique, maintenance of wire stability, and flow of operation all improved following the curriculum, with a score of 0 being fail and 4 being success or technically excellent. We also had these participants take a survey based on knowledge. Their procedural knowledge and time and motion also improved. In addition, we reduced procedural time from 7 minutes to 3.8 minutes. Now, I want to draw your attention here to procedural safety, where that was improved as well from 1.1 to 2.96. We also did an in vivo analysis of major themes of why these residents were facing such difficulty, and one of the primary themes that came up were unsafe maneuvers. In addition to difficulty using ultrasound, using the introducer needle, poor wire technique, and catheter handling, which is all understandable, one resident lost a wire within the patient. One resident broke the wire within the needle. Numerous residents attempted to advance a catheter into subcutaneous tissue unknowingly after losing arterial access. And fully 12 residents, nearly half the participants, attempted to use a cheater to dilate the vessel. We had to stop these participants from further doing this because they were destroying the models. So in conclusion, femoral artery access is associated with significant frequent errors by junior residents, and there are major safety concerns with them obtaining femoral artery access. However, our simulation-based curriculum resulted in improvement in across the board and improved procedural skills on all metrics measured. Thank you.
Judges.
Have you changed the curriculum for who can put in wires and femoral artery catheters at MGH? Do you have to do a minimum of 2 that are supervised or something of that nature based upon your study?
Currently at our institution, there are no restrictions, especially with emergency medicine residents in emergent situations. It appears that anybody can do these procedures. We hope to, before we create a boundary, to actually give them a chance to go through this curriculum.
Understood.
From the floor.
Hi, Ted Gifford, Hartford Hospital. Thank you for this presentation, really interesting. Do you guys have a line team at your hospital? We see that coming up more and more frequently now, whether anesthesia in pre-op or in our ICUs, and I think that unfortunately it means that our trainees, both surgical and otherwise, probably aren't getting as much exposure to line placement and could lead to safety issues. So, thank you.
That's a great question. We previously had line teams in the COVID-19 pandemic, but those were dissolved given the burden was decreased. And now we're back to having residents, fellows, and anesthesia attending supervised placement in ICUs. In the emergency department, there's no such line team as well.
All right. Thank you.
Thank you.
All right, that concludes our poster runoff, and the winner will be announced at the conclusion of the following session, which is the final session of the meeting. All right, thank you to all of our presenters. I'm going to announce the winner of the Alistair Karmody poster competition, and that is Dr. Richard Mina. Is Dr. Richard Mina here? For comparison of non-autologous hemodialysis grafts, bovine carotid artery versus synthetic.